The way we did it, we didn't have to touch the brain for Ellen. And you don't have to get an incision on your head. I think that's fantastic. So there are a lot of great things about it.
I mean, you must have just been amazed at the entire process.
Absolutely was. I wish I could have been standing there watching.
Fascinating.
Hi, this is Patrick.
And this is Laura.
And you're listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. National leaders in cancer. And today we're joined by Ellen. Ellen, you had a benign brain tumor, and you had it removed in March of 2023. And
Right.
Dr. Kim, you are her surgeon. Mm-hmm. And you have a very cool title because not only are you the director of the Brain Tumor Center at Siteman Cancer Center, but you are the August A. Bush Jr. Distinguished Professor of Neurological Surgery. And I had to look because I did not want to mess up such a distinguished title. So thank you for both joining us today.
You got it right. Thank you. No, thank you. Thank you, Laura and Patrick.
Ellen, we'd love to start off with your story and what brought you to Dr. Kim in the first place.
Probably the fall before 22, I was having difficulty focusing. My left eye was fuzzy, unclear, and like there was a film I was constantly trying to blink away. Mm-hmm. So I made an appointment with my ophthalmologist, went in, and eventually saw him in the following February. And he did his regular exam, but in the process looked behind the eye. And he said, I see a growth of some kind around your optic nerve on your left that has cut off the blood supply. He said, I want to send you to some friends over at Barnes, and we will see what they say. Unfortunately, the damage that's been done probably cannot be corrected or reversed, but we're going to wait and see what they have to say.
And for those listening, Barnes is the hospital that is connected with Siteman Cancer Center and the Brain Tumor Center. For those that are listening that may be confused by that word, there's lots of things that connect everyone together, right? And you mentioned when we talked before we started recording that you are not a worrier. And you just kind of wait until you're told to worry. And so you said, I just kind of said, okay, I'll go. You said your kids were pretty worried.
They were pretty worried, but kind of kept. They didn't let me know. I tend to be a little more laid back.
That's a great quality. I wish I had that ability, especially when it came to.
Been a lifesaver, and most of the time, it's enough.
So then you went and had the what kind of scan did you have or something?
MRI
was it an MRI, Dr. Kim?
Mm-hmm.
And how soon after you got that MRI did you find the news?
Within the 3-week period, I had seen Dr. Kim, a neuro-ophthalmologist, an endocrinologist, and Dr. Schneider, the ear, nose, and throat surgeon. Had seen all of those people.
Within 3 weeks? Wow.
Within 3 weeks, I had the surgery. So, again, luckily there wasn't a lot of time to get worried. Mm-hmm. You were just kind of bam, 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 bam. And everything fell into place.
And no part of you went, well, these are a lot of doctors to be seen? Or did you think it was just part of the discovery process?
I just thought it was what was required.
Gotcha.
Sure.
Yeah. So
how did that kind of progress? So, I mean, it starts with a CT, right? You're going to see a mass, and then maybe was there a PET to go with it to see if it was taking up, or was this just you do a CT, you see the mass, and that was probably enough information?
And MRI, I believe.
Yeah, it's CT and MRI for most benign tumors. And
Gotcha.
When I saw the MRI, I knew it was going to be a benign tumor called a meningioma, although just because it's benign doesn't mean it can't hurt you in some way. Obviously, it was affecting your vision. And I was just thinking, it's kind of amazing that you remember all the doctors' names and the people you visited.
Nobody usually remembers that. They're like, I don't know what this one does. I don't know if they're. I'm like, are you seeing an oncologist or who's your radiologist? I don't know.
Well, it's a lot.
Exactly.
It's a lot of it's a lot of information, and usually in a short amount of time, and it can be overwhelming. Did you usually have family with you when you went to kind of help?
My husband.
Okay. Mm-hmm. But did he have to kind of help remind you of stuff, or were you kind of locked in and you got the doctor's names and the terminology?
Had assigned to us a nurse navigator.
Mm-hmm.
Yeah.
Who is an absolute angel. And I am like, nurse navigator? Well, I can get myself to. No. Mm-hmm. She helped organize the lab work, which was like every 2 to 3 days for a couple of months. Doctor's appointment, she will call a couple times a week. How you doing? What do you need? Do I need to send visiting nurse? I mean, I had to do very little except be there. I had all of these people carrying me through this process. It was fantastic.
And so, Dr. Kim, tell us again what the diagnosis was and what that type of brain tumor means.
So just taking a step back, so half of all brain tumors, all brain tumors are scary, and I understand it doesn't even matter whether it's benign or cancer or malignant. A brain tumor is just scary. But it turns out that half of all brain tumors that we deal with are benign, so they're not cancers, but they can be troublesome. They can affect your vision. They can affect your strength on one side. They can affect all sorts of things. And for Ellen, she had something called a meningioma. It's a bit of a mouthful. But it turns out that is the most common benign tumor out there. So about 35% of all primary brain tumors are this tumor called a meningioma. They occur more so in sophisticated women like yourself, I would say. It's as you get older, there's more of a likelihood that you get it, and females tend to get it more. And it was going to, it wasn't only affecting her left eye, it was starting to affect her right eye. It was, when I looked at her MRI, this tumor was stretching her optic nerves like a rubber band.
Oh, man.
And so her right eye vision was also at risk.
Were you having a lot of headaches with it too?
No.
Really? Wow.
No.
To hear that it's stretching optic nerves like that, it sounds like it would be painful, but it's surprising.
I was trying to think back. Was there anything different? I've had sinus trouble all my life, and whenever I would have it, it'd be in the top of my head or right behind my eyes, and I thought, sinus.
Right.
Yeah.
I didn't think past.
And you showed us a picture of your MRI and that tumor, and it was like in the center, in the middle, in your brain, in the middle of the eyes, and it had a little hook that was leaning towards your left eye.
That's right, yeah.
Yeah, and so that hook was what was really impeding on that vision. Is that correct?
That's correct. So that was wrapping around her left optic nerve and causing swelling. You could see the swelling in the MRI. They call it edema. That's swelling, MRI speak. Yeah.
I'm curious, just I guess this is kind of more definition, but to hear that it's benign and not malignant, it could be benign but still growing. Is that correct? Malignancy is more spreading, not so much growth. Because when I hear benign, I'm like, all right, so it is what it is. But it could still be benign, grow, and then start pushing on things and impeding things. Is that correct?
That's right. That's
Okay.
right. So there are a few major differences between what we call a cancer or a malignancy versus a benign tumor. One is that benign tumors tend to be encapsulated. They're not creepy crawly, infiltrative. So cancers tend to be infiltrative. Cancers can also go to other parts of the body, although in the case of the brain, most cancers of the brain that start in the brain don't go to other parts of the body. So it is a little different that way. But usually cancers, again, are infiltrative, and then number two, they can, in many cases, go to other parts of the body. But the benign tumors will be self-contained, but they can still grow, they can still press on things that you need, and they can crawl into spaces, although encapsulated, that we can't get to sometimes surgically.
Or you can't, and like you said, you couldn't undo the damage that was done, Ellen told us, to the vision that had been lost due to that tumor, correct?
That's right. That's right.
But the goal was to get it out so that it didn't grow and cause any more damage.
Correct, so that we could preserve as much vision as we could on the left eye, and then save her right eye vision, obviously.
How often do you have to find yourself when you're talking to patients about a tumor? How often are they, so I have cancer. How often are you having to say this is not cancerous, or differentiate between benign and malignant? Because for a lot of people, cancer discussions and tumors and benign and malignant are not part of their vocabulary.
Right. That's a good point, because I don't think a lot of people know the definitions of malignant or cancer or tumor.
No, or benign. Or they'll say, does that mean good or bad?
Yeah,
benign?
I'm sure there's tons
lesion.
of base level.
Good or bad.
Yeah,
Right.
that's what I mean. I know there's half my friends wouldn't know if benign was good or bad, or malignant was good
Yeah,
or bad.
there's always a tricky. I mean, I'm sure you have, nurses will help with this. I'm sure you have to do a lot of it yourself. Physician's assistants, but there's always kind of an education period where you got to learn these terms of, is this good? Is this bad? Is this benign? Is it malignant? Negative and positive, even on
Right.
some tests, can
Right,
confuse
right.
people.
Oh, yeah.
But do you find yourself a lot having to really walk them through that when you tell them what it is that's going on?
Actually, the reality is that most people are relieved when you say it's not cancer.
Gotcha.
So that's one milestone. And then some people do ask about these differences, and then we have to explain it. You're right.
Right.
You're right.
One of the things we've met before and talked about, whenever you hear someone with a brain tumor, and I know Ellen's passed, she was tell me what the title of your job, because it was very cool.
Pathology transcriptionist.
Yeah, she was a transcriptionist for pathologists, and so you probably knew some medical lingo.
I know the words.
You know the words, but you also love to sew. You said, right? And so when you meet a lot of patients, you probably ask them, especially when it comes to whatever's most important to them, how can you preserve what it is that they do? If it's golf, if it's their vision, if it's their, I don't know, there's a million things that people love to do, right? That's an important part of your process when you're deciding to do surgery, correct?
That's correct. And there are other examples of this. I mean, obviously, vision is important for everybody, and especially for Ellen, because she likes to do embroidery and other things like that. And we'll get to that maybe a little later. I got some gifts from her regarding that skill of hers. But I have other examples of folks who, for various reasons, whether their hearing is really important because they're in music, or frankly, even their taste buds, their sense of taste is important because of their job, that we have to make certain decisions. Yeah, we have to make certain decisions about the treatment.
Which I think is incredible that you can, in some cases, take that into consideration, customize how you're going to treat this cancer to try to preserve these things. I mean, in my mind, it's like, I would think it's so complicated and difficult to deal with it. It's like, look, we're going to do what we can do. Hopefully we can, but to know that there are cases in which you actually have that level of control and finesse in the care to be like, okay, sure, we'll make sure we don't knock out any taste buds while we take care of this brain tumor for you. It's just amazing.
No, I completely agree. I think it's really been the evolution of surgical technology and surgical approaches. It's changed dramatically over the last, I would say, 1 to 2 decades. In fact, if Ellen had shown up, let me say, in the mid-2000s, I don't think we would have. I think it would have been a completely different way to get at this tumor. In fact, I would say, yeah.
That's amazing.
But back to this idea that you're talking about you have 2 dials here, right? You have one dial for the kind of tumor it is and how you approach that, and then you have the other dial, what kind of person is it? What's important to them? And so I always think about those 2 variables.
And Dr. Kim, I've had other projects I've worked with you on before where I've heard you say that not every brain tumor has to be removed immediately, right?
That's right.
Because we're talking about second opinions on this other project. So what led to the swiftness of this brain tumor being removed with Ellen?
So in her case, it's true the tumor is benign, but it was threatening her vision. And again, I didn't want her other eye to be affected, so I thought we should do it very quickly. In my view, this is an urgent surgery, even though it's a benign tumor.
Gotcha. And so did that make you feel better, or a little bit more like, oh, this is urgent, we're going to do this now? Like, I'm sure you probably said, like, okay, so we'll get you in next week. And were you like, I'm sorry, what?
No, I think that was kind of a godsend. The longer you sit around, the more things you're going to think. So again, it was a very good thing that it happened quickly, and it was just like, all right, I think at one point I said, what would you do? Would you wait, keep an eye on it? And he said, no, I think we'll just take it out and be done with it. And totally the best way to go for us.
That's always a great question to ask. It's always a good thing to hear, too, from your oncologist. Well, if it were me, I would do that. Or, I think a lot of times they're careful not to say me, but, if it were my father or, my spouse or whatever, here's what I would do. Dr. Kim, can you kind of elaborate a little bit on how not every brain tumor needs to be treated right away? I mean, there's such a variety of tumors, brain cancers, that you come across as tons of treatment options. People you've got your person dial and your treatment dial. How do you go about figuring out, well, with this kind we can wait, and with this kind we should move? I
see. That's a really good question. I think there may be 2 layers to this that I could speak to. One is that if it is a benign tumor and it clearly looks that way, on an MRI, and often you can tell, even though you don't have pathology or something like that. You can tell on the MRI or CT that it's going to be a benign tumor. If it's not growing, and if it's not causing some kind of a deficit in your function, like if it's not affecting your vision or your movements or something like that, you can generally wait on those benign tumors. Now, psychologically, some people are troubled by that. So given the right size of a tumor, not like a pea size or a tiny tumor, but if you have a reasonably sized tumor and it really bothers them emotionally, that can also be an indication. But generally speaking, for benign tumors, they have to grow or cause problems. Now, if it looks like a malignant tumor or it's ambiguous, I don't know if it's malignant or benign, then I think you have to do something about it right away, because you're just losing time if it's a cancer. So that's one layer, but the second layer is, even if it's malignant or even if it's affecting, let's say, function, you still have a moment to breathe. And you don't have to rush to your local ER to get this done. You want someone who knows what he or she is doing to do this. So you have a day or two at least, if not more, to think where you want to go to get this done. And that's why I would argue you need to go to some place like Siteman Cancer Center or the Brain Tumor Center here to get high-end help, because we've seen a lot of things like this.
So the part that fascinates me the most about brain tumors or brain surgery is the act of doing the surgery. So, I mean, I always envision the person's awake. I don't know if that's true, but could you tell us specifically what you did to remove Ellen's tumor?
Yeah, so all of our surgeries are not awake. I think we reserve awake surgeries for specific cases where we need feedback. For instance, language. And then occasionally some people will also do it for things like motor or for sensory. So something where you really need feedback on. The level of tension in a room with an awake is just slightly higher because you don't have a secured airway. That's the primary reason awake procedures are a little more stressful. Yeah, because you don't have a tube inside someone's lung that will help them breathe and will protect their airway. You have someone who can talk and they're under anesthesia. At any moment in that situation, you can lose your airway and that could lead to, you suffocating. So the awake procedures, you have to really it's game time. And you have to make sure that airway is preserved. So that's the added risk in an awake. So we try to do that only when you need, again, like I said, feedback. Yeah. Like you need to talk to them. In Ellen's case, we did something. We did something fancy again, which didn't exist.
Well, you're a fancy lady.
Which didn't exist before. I would say mid 2000s. Generally in the United States, we did something called an expanded endoscopic endonasal surgery, and just to unpack that, so it's an endoscopic surgery. So that means we use these like James Bond type scopes. So they're 4 millimeters in diameter, and now they're 4K. They used to be HD. Now they're 4K, and so you can see it's a panoramic view by putting them into any space. Number one. So and so that's endoscopic. Endonasal, because we go through her nose. We don't do an incision anywhere on her head. It's amazing. Cut the bone, drill the bone, and take it off. Go underneath the brain. We're going straight shot to the tumor through the nose. So that's endonasal. And it's expanded because this tumor was just dripping around the optic nerve, as we were saying before, and it's also dripping forward. So the tumor covers a big area, so it's an expanded endoscopic endonasal surgery. That's what we did for her. So, I mean, in some sense, it's incisionless, at least cosmetically, and it's a straight shot to the tumor. We don't have to pull on the brain, retract the brain to get to the tumor. So that's what we did for her.
And everything is extracted through that same passageway that you used to get access to it, huh?
That's right, yeah.
Wow.
But the tumor was like the size of an eyeball, so how did it come out of her nose?
Yeah, her tumor was, it was pretty big. It was probably...
Like a golf ball?
Yeah, I would say it's closer to a golf ball. And
wow.
Did you know that?
No.
Ellen's face was like, if you go to YouTube, you'll see, she was like, wow.
Yeah, but because you're not touching the brain, I think there are a lot of advantages here. That's why, frankly, we could preserve some of that vision in the left eye and also completely preserve vision on the right, because you're not looking through blind spots, which would be what you're doing through a craniotomy through the head. Mm-hmm. just to paint a picture, so the tumor's right in front of you, and the nerves, the optic nerves we're worried about, are above that. Okay?
I see.
And so we can basically get rid of the tumor little by little, and then suddenly you can start seeing the two rubber bands that are the optic nerves, and then you can very carefully dissect those nerves away from the tumor.
I see.
Now, if you do it from above, there's a brain you have to get under, and then you usually have a blind spot because of the optic nerves. There's a blind spot. For lack of a better, clearer explanation, there is a blind spot when you go through a craniotomy, which you don't have when you go through the nose.
Sure.
That is fascinating to me. Ellen, is that fascinating?
When he said, he was so excited, Dr. Kim was so excited, he says, we're going to go up your nose.
It's going to be
We're
awesome.
not going to have to make a door in your head.
Yeah.
He was so excited. And I was very calm, but in my head I screamed a cartoon, up my nose.
Oh my gosh.
But then how fantastic
Right.
that was.
How minimally invasive.
Yes.
You know?
Absolutely.
How does the golf ball sized tumor get dissolved enough to the point that it can be basically sucked out of the nose?
Yeah, this is a great question. So this is a very common question that I get from patients, but the idea is, let's say you have a big grape, and that's what the tumor is. The idea is to take out the meat of the grape and then leave the skin. And then you just dissect the thin skin from the important stuff, like the nerves and the arteries. Because you don't want to take a big, like let's make it absurd. You don't want to take a softball that's stuck to all of your nerves and arteries and then just wiggle that huge ball around. You want something pliable and thin to dissect off those important structures. So that's the idea. Take out the grape meat, the meat of the grape, and then leave the skin and then dissect the skin.
So is that
gently.
Nasal tube that goes up there, does it have like suction on it so it sucks out the meat of the grape, you say? Like how does that work?
Yeah. So this is a good question. So this is why I should mention my buddy, Dr. John Schneider, that Ellen mentioned as well. So we do this. So he's an ENT surgeon in rhinology, and so we do the surgery together. So he's driving the scope, the endoscope, and then I'm using both my hands through both nostrils, one with a sucker, the other with a dissector, for instance. And so it's literally 4-hand surgery because we have Dr. Schneider and myself doing things at the same time.
And are you guys using the machine, or is your hands like up against her nose?
It's our hands, and then we're looking at a 4K screen.
I see.
Yeah.
So you've got a monitor up through the nose, and then the monitor stays in place while you are basically watching the monitor and doing your surgery via hands. That's
correct. There's some parallels to video games in this sense. Yeah.
I mean, how is there room for 4 hands up against someone's nose? I mean, if I put my 2 hands up to my nose.
I'm just loving the articulation that you have of that. Does it when it sucks it out of there?
I keep thinking like of a shop vac. Like I was shop vacuuming. I was cleaning my porch yesterday, and I was trying to get all the leaves. Like I envisioned this tiny little tube that's like a shop vac sucking that grape meat out, and then the more technical, tool that's trying to get then little by little get the skin so
that's
it doesn't
right.
affect anything.
Yeah,
I mean, basically I'm a
that's
neurosurgeon,
correct.
right?
Yeah, I think you could do it today.
Strike that from the record.
I'm just fascinated. Like, how do you go, can you move your hand so I can get the endo up there? I mean, you have normal sized hands. It's not like you have tiny hands.
Well, the instruments are the things that are going through the nose.
Right.
And no, but you're right. You have to learn how to collaborate with your buddy so that you're not in each other's way. That definitely is a skill you have to learn.
Yeah. Did you feel anything when you woke up, Ellen, or were you?
I never had a stitch of pain.
You didn't
Ever,
have like a
maybe some pressure, but minimal. I was just like, well, where's the pain?
And
I had a big procedure. Where's the pain?
And so, I mean, I guess if you had so little pain afterwards, was the recovery, did it flare up a couple days later, or, you just walked out of there?
Just like the day I walked in, truly, I was kind of blessed, very blessed.
So just to back it up to, the start of this whole thing, I mean, it sounds like it all went pretty quickly, right? I mean, when you're having this blurred vision, had you had something like that before? Was it the first time? Were you thinking?
It probably came on so slowly that I was buying stronger readers at Walmart. That
just kind of compensating.
It was fine. And then when we got the strongest ones available and it wasn't really helping, I thought, time to get some big girl glasses,
And
go
so
see.
It's in the appointment with your ophthalmologist that they right away they see something.
He saw.
And that was 5 months after you initially called. You called in October of 2022, saw him in February of 23, and probably had your surgery in March. Wow.
Like
So-
16th, I believe.
So it's a recommendation from the ophthalmologist that lands you at Siteman
Right.
and the Brain Cancer Center, and it really just went that quickly, huh?
Mhm, it did.
This is a very common story, though, I hear, that this slow, insidious progression where you don't even notice, but then suddenly you're almost blind in one eye. That's a very common story that I hear, especially with these benign tumors.
Yeah, I was going to ask you, that size that you found, about the size of a golf ball, can you tell how long that must have been growing? Is there a way to know?
It's hard to know,
Yeah.
and sometimes it's fits and starts, too. Sometimes you can see a tumor grow a little, and then it stops growing, and then it'll grow later. So it's hard to say, but I mean, my best guess would be that probably in the last, leading up to it, in the last year before I met Ellen, it was probably growing a little, and that's why it was affecting her vision. But beyond that, it might have been in your head the last 5-10 years. That's possible.
Wow.
Well, I see the ophthalmologist yearly, and he didn't notice it on her previous exam, which maybe was a year and a half before I saw you. So sometime in that period of time, I would guess.
Yeah.
What are the main reasons you'll see someone come in with a symptom of a brain tumor that is a brain tumor?
So a symptom that's from the brain tumor?
Yes. Most common.
I think it depends where it is, and it depends also on the rapidity of the growth. So if something's been slow, it can be incidental almost. Like, for instance, what I mean by incidental is they got into a car accident and they found this tumor.
Yeah.
That happens very commonly. And then in terms of symptoms, it just depends where it is. So for Ellen's, it was near her optic nerve, so that's going to affect her vision. Other people, let's say it's on the right side of my head, in the middle of my head, that will affect strength, let's say on my left side. Some people present with seizure, which is kind of like your brain being tickled.
Or like speech, maybe.
Yeah, so if it's on the commonly on the left side, real low, then that could affect your speech or even how you understand speech. Yeah, that's right.
So what makes the Brain Tumor Center so unique at Siteman Cancer Center? Because it's not cancer brain tumors, it's the Brain Tumor Center, which means a wide umbrella of brain tumors, correct?
Oh, yeah. And I mean, I'm glad you brought this up. I'm really so proud of the Brain Tumor Center here. My colleagues are so incredible. The institution's so supportive. And I think we are just really one of the best teams in the country in terms of taking care of tumors. And it extends beyond that. It's not just the clinicians, the surgeons, the neuro-oncologists, the radiation oncologists, radiologists. Actually, the list keeps going. It's not only the clinicians, it's also the science. It's making new trials that will become the new standard of care in the future. That's also going on here.
And the tools that you guys have there.
Oh, yeah, for sure. The technology is just...
clearly this technology was
Oh, yeah.
amazing, right? I mean, and how long has the Brain Tumor Center been in existence?
So formally speaking, the Brain Tumor Center was established in 2020, so not that long, 5
Right.
years. I mean, there's been a brain tumor program here for a long time, but I think there's been a lot of investment over the 5 years in terms of making it, the best in the country. That's our goal.
And talking about why it's one of the best in the country, I mean, we were talking, it's not just the physicians and the science, but the tools that you guys have and
Yeah.
the methods that you guys use. Like I know you guys, I always, call it, doctors will round. You guys will round in a way where it's a board. It's a brain tumor board where you guys all huddle up and discuss a number of cases and weigh in. Can you describe what that workflow is like?
Oh, yeah. So that's a multidisciplinary tumor board. We actually have 3 different kinds of them.
Wow.
So the one for the general brain tumors, and a lot of them are malignant, it's on Mondays, every single Monday. But then we also have special ones for what we call skull-based tumors, and those are generally more complicated. They tend to be benign, and we have 2 of those. And so for tumors like Ellen, we discuss her case at something called the anterior skull-based board. There are other types of tumors around your brainstem, back in the posterior part of your head, and that's lateral skull-based board. But for Ellen, we discussed her case at the anterior skull base board, and it's
Did you
not,
know that, Ellen?
I did not.
Oh,
yeah.
there you go.
And so, we discussed her case with ENT folks, neurosurgeons, endocrinologists, because her tumor is really close to the pituitary gland, which is the conductor of the endocrine orchestra. And so we have everybody there that she would need thinking about her.
And when you were chosen to be director, how did that come about, to be the director of the Brain Tumor Center?
So, I mean, that's an incredible honor, first of
Yes.
all. I think I would not have anticipated that if I look back when I was in high school, let's say, or college or something like that.
What were you doing in high school?
I was playing with my friends. I was
Yeah.
doing a lot of science, I have to say.
I was going to say, there's no
liked
way you went
science.
and got your medical degree at Harvard and weren't studying in high school.
Yeah, I mean, I had the ability to focus. That's true, but I didn't know what my passion was going to be. Quite honestly, I think maybe I thought I was going to be in the medical field, maybe, but I didn't think it'd be neuroscience and neurosurgery. But so this director thing, it's really an honor. But the main role of the director is to set the vision for the future. I mean, what are we going to do with all this talent, technology, science, trials, right? And so that's just been a lot of fun, and mostly because I have these people that I work with that are just fantastic, and it's people like the scientific director Alex Stegg, it's a clinical director Jay Huang in radiation oncology, it's our new medical director Tanner Johans, and the head of the director of neuro-oncology, who is Milan. It's all these people. We're always endlessly brainstorming, try to make things better, recruiting people. So that's my role, really.
Gotcha.
And that's what you had working for you,
Yeah,
Ellen.
yeah.
He's a gift.
I mean, you had
It's a
like
gift.
the piece of the resistance of neurosurgeons, right?
And we realized it right away.
Yeah. When you talk about things in the future, earlier this season, we did an episode called Navigating the Treatment Plan, and we had a father who now is on the Patient Family Advisory Council, and he himself had prostate cancer, but he cared for his
wow.
son through a glioblastoma. Do you all have some hope for brain tumors like that are so difficult to battle? Yeah.
Yeah, I mean, glioblastoma is a very difficult nut to crack. It's a lot like pancreatic cancer, for instance, and some of the treatment refractory breast cancers, et cetera. I think there have been a number of discoveries over the last 2 decades, but what we really need is a transformation, right? The last big change in the standard of care actually was a device, maybe just 5 years ago. It's a current device that you put on your head. It's called Optune, and so that's a relatively new thing. But before that, the biggest change was in around the year 2000. It's kind of crazy.
Wow.
Which is the standard of care of radiation therapy and something called temozolomide, which is a chemotherapy. So that's what we're working with here. And so we need new clinical trials to change the state of these patients. I mean, we have to do something. It's an urgent thing. And so I think there are a number of different things across the country that people are thinking about, and we're absolutely thinking about these things. One of the big things is immunotherapy. Immunotherapy has completely transformed things like melanoma, right?
Yeah.
I mean, who would have known Jimmy Carter would have lived that long? That's crazy. I mean, it's amazing. But the immunotherapy really hasn't taken off so much for glioblastoma, and there are a few reasons for that. One of the big ones is that that you have something called a blood-brain barrier, and so most medications you take by mouth or in the IV, they just don't get into your brain. It's probably an evolutionary protective mechanism, so you don't get bad stuff in your brain. But that prevents medicines from getting to your brain tumor. The other thing is that for whatever reason, the brain and the brain environment, it tends to inhibit immune responses. Maybe that makes sense because you don't want, I'm just thinking I had a mosquito bite yesterday from a Labor Day party, and I'm paying for it today because it's swollen now. You don't want that to happen in your brain. If you have some kind of infection or inflammation or tumor and it swells, it's like filling a hard box with water. The pressure is going to go way up at some point if because of that inflammation. So it kind of makes sense to me that the brain would be inhibiting the immune response because it's probably protective. But in the case of brain tumors, it just prevents any immunotherapy from working.
I have a question for you, Ellen. Did you ever ask or wonder, could this come back?
I think we did.
Yeah.
And just had an MRI May, I believe.
I saw it, yeah.
And we'll follow that one more year.
Yeah, that's right. And then we'll lengthen the intervals for the MRI. So I would say a tumor like Ellen's, which is meningioma, a benign tumor, a grade 1, the recurrence rates are very low. I would say it's like 5% or less, something like that.
That's going to make you feel good.
Yeah.
Yeah. And when you said you often find these types of tumors in sophisticated women, do you know why that is? Is there any research about what particularly in sophisticated women, why these are showing up?
Well, I would say...
And you are very sophisticated, Ellen,
Thank you.
for the record.
I think
Thank you.
there are
I mean that in a sophisticated word.
there are at least two reasons, I think, for that. One is, for a lot of brain tumors, there's a randomness to it. Sometimes I call it bad luck. And so what I mean by that is the cells that give rise to a tumor like that, and actually even to glioblastoma, which is a totally different tumor, like we're talking about, you have normal cells that are dividing throughout your whole life in your brain and in your body. But just like a copying machine, that copy is not perfect. And so you have errors that happen in your DNA, and your DNA is what makes a cell. And so if you have an error in the DNA and that error causes that cell to just stop listening to the rest of the body, that's the beginning of a tumor. And so that's what I mean in terms of a lot of brain tumors have to do with like this sort of random chance, bad luck error that occurs when you just have a cell divide. You have enough of these mutations in the wrong place, and then you have a tumor. And so in part, that's why you see older people with meningiomas. In part, that's why you see older people with glioblastomas, actually. So there's that element of it. And for meningioma specifically, you see it way more in women, like 3 to 1, I think.
Wow.
And I think it has to do with, in part because of the hormone receptors. So you do see some female hormone receptors on meningiomas, and that probably has something to do with its evolution or it's how they come about.
And so what do you feel like this surgery that Ellen had, you said would not have happened 15 years ago?
Right. We would have done this 15 years ago through probably, a traditional incision behind the hairline, which is probably about 10, 15 centimeters long. We would flap essentially deglove the face a little, the upper part of it to expose the bone.
Don't love that word.
And then we would drill out a piece of bone that's, I don't know, something like 7 by 7.
Wow.
And then we would have to go under the brain. The way we did it, we didn't have to touch the brain for Ellen, but we would have to go under the brain. Again, there's this the pesky thing again about that traditional approach is you can't see all parts of the tumor that way. There's again that blind spot I was mentioning because of the angle, and so I still have to do that sometimes because of various reasons. Because usually it's the configuration of the tumor that prevents me from doing it through the nose. So I still have to do that, but I firmly believe that doing this through the nose has superior, let's say, visual outcomes for sure. And you don't have to get an incision on your head. I think that's fantastic. So
Yeah,
that was a
a lot of great things about it.
I mean, you must have just been amazed at the entire process.
Absolutely was. I wish I could have been standing there watching. I think that would have been one of the most. So we went home. My husband pulled up similar surgeries, and we watched. It was like, oh my gosh, absolutely amazing,
Fascinating.
I believe it was Dr. Snyder who said, I can't remember if it was you or Dr. Snyder said, we got up there. It was great. What we did was cut a little bone. He said we made like French doors behind, at the top of your nose, between your, and we had so much room to work up there. He was so excited. I was like, I'm so glad.
Yeah, no,
He
that
was
you're
just
actually
thrilled the way they could approach.
You
That's
described it so accurately. Wow. Again, your memory is incredible.
Well, I
but
think
that's
it's her.
exactly correct. We drilled a bone in a huge rectangle, but because of the perspective, it looks like a chef's hat. Actually, it looks like a chef hat, the bone we drill. And then we open it in the form of a letter I, so it looks like a French door. You're right.
gosh.
Yeah.
Are you fascinated still on a daily basis with what it is that you do?
I love what I do. I mean, it's such a privilege. I can't believe I'm allowed to do this. I mean, that's what I think. At the same time, it's amazing what you get used to over time, and so it's both, you know. Mm-hmm. And your feelings about it change over time. I was saying to a patient the other day, I've probably done more brain tumors surgeries now than I've eaten hamburgers. That's probably true. There probably is nothing else I've done in my life that I've done more than a brain tumor surgery.
Wow.
Which is kind of an amazing thing to think about.
Right.
You know? And so it's very comfortable to me now. And I would much rather do brain tumor surgery than, let's say, take out and refinance my home. That's so stressful.
Right. Exactly.
But doing a brain tumor surgery, know what to do. It's serious and things could go wrong.
Yeah.
I don't get me
I want
wrong,
my
but
surgeon to be relaxed like
but
that
yeah,
going in, right,
but
Ellen?
it's relaxing to me, yeah.
Absolutely.
With the Brain Tumor Center being, newly in the last 4 or 5 years, right? What are you working on, hoping for, have on your horizon in the next 10 to 15 years? Like, what is the thing that's possible?
Oh, yeah. I love this question. Well, we're obviously, as a in neurosurgery, and as a neurosurgeon, we're obviously going to be pushing the technology in surgery, and things will get more minimally invasive and more robotic. We use robots now, in fact, with our lasers. And similarly in neuro-oncology, and in radiation oncology, we're going to have more technology, more medications. I mean, radiation oncology, it's like a candy shop. They have every single tool you would want to use to perform any kind of radiation therapy or radiosurgery. They have every toy they would want in the universe. So the great thing about that is you're not biased. You just don't have one hammer that you use on everything, even if it's not a nail. They can pick the best technology for the patient. So that's one thing that's moving forward, the technology. But it's really about the clinical trials, honestly, because that's going to make the new standard of care, especially for something like glioblastoma, right? And so there are a number of things we're trying now that I think are really exciting. I would say I'm involved personally in trying to improve the lasers and the robots that I was just talking about. So we use laser therapy to kill tumors inside out. So through a tiny hole, 4.5 millimeter hole in the skull, we can stick in a laser probe into the middle of a tumor without really injuring any brain, and then kill that tumor inside out. So that's happening already. We've been doing that for 10 years because of Eric Luthart, who's a colleague of mine who brought that technology here. Now, it turns out it does other things, though. It doesn't just kill tumors. It also opens the blood-brain barrier locally. So you can imagine drugs getting in the local area for about 4 to 6 weeks, number one. And then more recently, we've been interested using a little mini mouse laser. So we're modeling this in the lab. We want to add lasers with immunotherapy because we've found out that the laser ignites the immune system. So I said before that the brain is very suppressive of the immune system. It's hard to get immunotherapy to work. We think that the laser therapy might unlock that. So that's
literally opens it up, essentially, right?
Yeah, that's right. That's one thing. But there are a lot of other things going on, and happy to talk about those too.
Sure. But it sounds like the overall vision for the future of Siteman's Brain Tumor Center, the Brain Tumor Center at Siteman, is really just keeping the ball moving forward, continuing the advances in clinical trials, the technology, and just making sure all the brilliant minds there have the tools they need to keep innovating. Yeah, no, I agree. I think, there's certain focus areas that we want to push as a center, but I think that incrementally first, but then suddenly transformatively, I think things will change. I actually think things are going to be transformed in the next decade for glioblastoma. I really do. We're on the cusp of that. I feel that. That's so cool.
So exciting.
Yeah. Ellen, I'm curious, how has this entire experience, if at all, changed you? You seemed very zen to begin with, and it sounds like you took the diagnosis in stride and had a very successful outcome, but still, it is, I don't know, I would imagine still kind of grounding or humbling in a way to have to go through this.
Humbling is a great word.
Yeah.
I think what hit me maybe about probably when the steroids wore off and I came back to earth, they kind of kept me flying there for a while. All of a sudden, it hit me one day. You're not 45.
Mm-hmm.
You might, not be able to do a lot of things you used to do, which isn't the case. But I've had to face my mortality, which I know I never thought about before.
Really? Mm-hmm. And to be able to get through it too and have your independence preserved because your vision is preserved. I mean, the gratitude you must have, I'm sure, is,
the first
incredible.
day, 5 weeks, you said you can't drive for 5 weeks. That was a very hard adjustment to me because I'm not, let's sit around.
Mm-hmm.
Yeah.
And my kids, sit down. I'll get that. Don't do the.
Yeah.
And that was very hard.
I'm sure.
It is for a lot of patients, I'm sure, that the recovery and letting other people care for you is always a difficult challenge, right?
Just not doing something all day, getting up and hop in the car, go somewhere, pick something up, come back, lift a gallon of milk. You can't do that for 5 weeks.
Yeah.
I was so blessed not to have pain to deal with, healing to deal with. It was just curtailing activity for a while and just accepting. I mean, my family was absolutely fantastic.
Yeah.
They carried me.
So I am really curious, Ellen, what was it that you made for Dr. Kim?
Oh.
You embroidered.
I knew before the surgery that he had a love of Bach. So while I was recuperating, I wanted to see if I could stitch ever again. So I think yours was the first project I took on.
Yeah.
Oh, wow.
And it said, the doctor is out, Bach soon.
Nice. Very clever.
That's very, very good.
Also, a Terminator reference.
Yeah, I'll be Bach.
I'll be Bach.
I forgot.
Yeah, but he didn't spell it B-A-C-H, right?
I don't know that it was ever spelled out.
Well,
He said
making
it
a pun.
BAC.
That's right.
Yeah.
That's right.
No, but I love that. I love that gift. That's sitting on my my lab desk right now.
Oh,
Yeah.
that's sweet.
Oh, that's an awesome gift to have, to know that not only is that from a patient, but from a patient whose eyesight is allowing her to do the thing that she loves to do.
Absolutely.
Right.
Yeah. No, it's incredible that I love that gift. And in fact, she just gave me another one recently that says, I am Baroque because I have no Monet, M-O-N-E-T. So
You're
super nerdy. I love it.
Well, I could literally ask you questions about brains and surgery and everything all day long. I think it's fascinating, and I'm so glad there are people like you in the world. And Ellen, just the ease in which you were able to go through this process and the support is so amazing. I can't think of another word other than amazing.
Thanks for sharing your story. And I'm looking forward to seeing what you knit next.
This is cancer. Can we get a knitted "This is cancer" logo?
Yes.
Oh,
That's a big ask.
That's a big ask, but that'd be cool.
That would be a...
No, but she's going to put a joke in it, though.
That's fine.
Knowing
That's
Ellen,
fine.
she'll put some humor into it.
Thanks for listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis.
National Leaders in Cancer.
For more information on Siteman Cancer Center, go to siteman.wustl.edu and be sure to leave us a review and like and subscribe wherever you listen to podcasts.